Hello, this is Mark Bierce. I'm the Program Director for the Bioidentical Hormone Initiative. I would like to welcome you to today's webinar, Emerging Concepts in the Diagnosis and Treatment of Hyperthyroidism, Part 2. This is a follow-up to a webinar that we did 2 weeks ago. Dr. Holtorf has agreed to come back and continue his very interesting and incisive commentary on hypothyroidism. And this part 2 will be followed in approximately 2 weeks' time by a third part where we'll finish up. So to begin, to remind everybody who wasn't able to attend the webinar 2 weeks ago, we do have the previous installment archived and available on the BHI website. So on your screen you'll see a URL where you can access it. You can view it as many times as you like. We've also included some of the references and additional information that Dr. Holtorf provided for us. So we welcome you to visit the website and check it out. A note about BHI. BHI is a community of physicians dedicated to the treatment of age-related endocrine dysfunction with bioidentical hormones and other evidence-based integrative therapies to improve quality of life, prevent chronic illness, and obtain optimal health. You can find more information about BHI at our website, bioidenticalhormoneinitiative.org. I welcome you to visit it. We try to regularly post interesting articles, research, references, and of course all of the archives from previous and future webinars that we'll conduct. You can also join BHI for free at the website to receive updates and news and information about upcoming events. So we welcome you to join and to participate. Before we get started, I want to make a quick note. On Saturday, September 17th and Sunday, September 18th in Madison, Wisconsin, BHI will be holding its first annual symposium, Evidence-Based Approaches to Age Management, Growing a Successful BHRT Practice. We have an interesting lineup with a number of well-known experts in the bioidentical hormone field. We have a full agenda of interesting lectures and presentations for that weekend, and we welcome you to join. If you would like to find out more information about the event, again, you can go to the Bioidentical Hormone Initiative website to find a full agenda, information about the speakers, and information about how to sign up. Today's webinar. Today's webinar is going to run for approximately 60 minutes. We'll try to reserve the last 15 or 20 minutes for Q&A. Dr. Holtorf has prepared a lot of material for us, and we'll be getting through the second part of that material today. We'll try not to run over because we know that everybody is busy and has taken the time out of their day to attend this event. If you're unable to attend the entire event or you have to leave early, again, by the end of the event, we will be preparing and uploading an archived version of the event for your reference. I would also like to comment that if you would like to ask Dr. Holtorf a question, you can type your question into the questions box in the webinar control panel, which should appear on the right side of your screen. About Dr. Ken Holtorf. Ken Holtorf has personally trained numerous physicians across the country in the use of bioidentical hormones, hyperthyroidism, complex endocrine dysfunction, and innovative treatments of chronic fatigue syndrome, fibromyalgia, and chronic infectious diseases, including Lyme disease. Kent is the medical director of the Holtorf Medical Group affiliate centers, the medical director of the nonprofit National Academy of Hypothyroidism, and was the founding medical director for fibromyalgia and fatigue centers. He's a diplomat, board examiner, and fellowship lecturer for the American Board of Anti-Aging Medicine and the endocrinology expert for America Online Health. Dr. Holtorf is a founding director of BHI and a senior faculty member of the Bioidentical Hormone Institute. Again, if you'd like to ask Dr. Holtorf a question during the course of the event, go to the comments section, the questions section in your webinar control panel. If you'd like to follow up after the event with a question, I would also encourage you to go to the BHI website where you'll find a forums section. Forums are available to any registered users, and there's often interesting discussions about the topics that are addressed in these webinars as well as other topics, and we'd love to have your participation. So without further ado, I'm going to pass over control of the event to Dr. Holtorf. Dr. Holtorf, whenever you're ready, you can turn on your slideshow and...
All right, you can see that, I assume? Thanks so much, Mark. I appreciate it. And as he said, this is the second part of the emerging concepts in the diagnosis and treatment of hypothyroidism. In the first part, we talked about the basis of thyroid function, and we talked a lot about the inaccuracy of TSH testing and about deiodinase activity, local control, resulting in T4, T3 conversion and reverse T3. In this part, we're going to talk more about thyroid transport, which is a big topic and very important, and not very many people are talking about it. Even more important than the deiodinases and the T4, T3 conversion is actually the transport into the cell. We'll talk about some specific conditions that really require T3. Although, again, the standard blood tests look normal, unless you look at it a little differently. And then we'll talk about, if the TSH isn't reliable, and what test do you use? Heck, standard tests that you normally do, well, then how do you diagnose it? So we'll talk about that. And then the third part, we will talk about, well, how do you treat it? So we'll move on again to a thyroid transport. And we've been taught in medical school, and still taught, that what's in the serum basically is going on in the cell, but that is totally incorrect. We're taught that there's passive diffusion. Whatever level of T4 is in the serum, it must be inside the cell. Or level of T3 is inside the cell. But that's shown not to be the case. There is no passive diffusion. It is active transport. And a couple keys to that is also found is that there's different transporters for each hormone. So T3 has a particular transporter, and T4 is a particular transporter. And reverse T3, interestingly, either has the same transporter as T4 or the same pharmacodynamics and same pharmacokinetics. And we'll show why that's important. And it shows that when you have a high reverse T3, that you can't use T4. Okay? And we'll explain that. So in order for the T4 to T3 to get into the cell, that it must be actively transported. And this is shown to be the rate-limiting step. So it's actually the most important step, and it actually varies significantly with the amount of energy that's available for that cell. So with any condition that has reduced energy, which includes mitochondrial dysfunction, any inflammation, diabetes, and we'll go through all those things, that you have a suppression of the T4 and T3 transport. But another very important fact, a couple of important facts, are that the T4 transporter is much more energy dependent than the T3 transporter. So again, with times of stress, with all those conditions, chronic fatigue syndrome, fibromyalgia, diabetes, chronic inflammation, chronic infections, the T4 transporter doesn't work very well. It basically quickly suppresses, so it doesn't transport T4 into the cell. Which is why T4 doesn't work in these conditions. Now, another important fact is that we showed in the previous lecture that the pituitary thyroid receptors are completely different than what's in the rest of the body. Deiodinases are completely different. The pituitary is a different beast. It doesn't correlate with what's going on in the rest of the body. And the same is true for the transporters. It has completely different transporters that are not energy dependent. So if there's a reduction in the transport of T4 and T3 into the cells in the rest of the body, it doesn't happen in the pituitary. So the pituitary is happy. It sees thyroid, TSH drops, while the rest of the body, the cells are starving. But the serum levels are going to go up because there's no transport into the cell. So again, we thought that basically serum levels tell you what's going on in the cell. Totally not true. In order to have biological activity, the T4 and T3 must cross into the cell. And the activity of these transporters really are the rate-limiting step for thyroid effect. And again, this diffusion hypothesis was, since 1960, it's still being taught. And so we'll look and see if that's really true. So the hypothesis of mechanism of thyroid uptake in the cell is shown to be totally incorrect in references 1 to 43. And again, you can get those references from the National Academy of Hypothyroidism, the nonprofit, nahypothyroidism.org. And under thyroid hormone transport, there's a whole review on that. So 1 to 43 showing that it's no diffusion. Clear showing the rate-limiting step, so it's the most important step, but no one's talking about dysfunction in the thyroid transport. Nothing to do with diffusion. It's energy. It requires energy to actively transport, and it's still being taught. For now, because it is the transfer of the cells is energy dependent, any condition with reduced production of cellular energy will also be associated with reduced transport of thyroid into the cell, but the blood test will look normal or even elevated, and we'll see that especially with T4. So what happens is you'll get, let's say, depression is a key, we'll talk more about this, is a key condition when there's abnormal thyroid transport, that the pituitary sees thyroid, but the TSH drops, the T4 transport goes down, so what happens is the serum level of T4 goes up, but the TSH goes down. So, you know, people say, well, they're a little hyperthyroid. It's the opposite. They're actually low thyroid. But T4 doesn't work in depression very well because there's very poor T4 transport. Now, T3 works much better because T3 is much less energy dependent, and so it will get into the cell better. There is reduction, but it's much better. And now the fact that, again, reverse T3 has the same pharmacodynamics, same pharmacokinetics as the T3 transporter. So when reverse T3 gets high, people think, well, because there's more T4 to reverse T3 conversion. But that's actually a minor factor compared to the transport. The reason there's high reverse T3 in the serum is that there's poor transport. And when you have poor reverse T3 transport in the cell, which is a marker being high reverse T3, you know T4 has a problem getting the cell. There's reduced transport into the cell. So high reverse T3, don't use T4. It won't work. So conditions associated with reduced mitochondrial function, impaired thyroid transport include insulin resistance, diabetes, and obesity. The reference is there. Chronic and acute dieting. So just dieting. You know, basically the thyroid won't get into the cells. It's blocked. The thyroid transporters are blocked, both acute and chronic. So it's a reason that, and we looked at the studies last time, when people basically do yo-yo dieting, chronic dieting, the body goes into that starvation mode, and the thyroid's not transported in the cell. And we talked about in the first part also there's reduced T4 T3 conversion in the cell, there's increased T4 to reverse or reduced T4 T3 conversion, increased T4 to reverse T3, which blocks the thyroid receptors that we talked about. So all these things reduce the thyroid activity in the cell, reduce metabolism, but the serum levels may look even better because the TSH drops, the T4 goes up, and that's what people are checking, but again, because it's not getting into the cell. Diabetes, depression, anxiety, bipolar depression, neurodegenerative diseases, aging, chronic fatigue syndrome, fibromyalgia, migraines, chronic infections, physiologic stress and anxiety, cardiovascular disease, inflammation and chronic illness, and those with high cholesterol and triglyceride levels. So even these high cholesterol and triglycerides block the thyroid transport. So again, we think it's so simple. Look at the TSH. Well, that's shown not to work. Well, look at the serum levels of T4 and T3. Well, it's actually oftentimes the opposite of what's going on inside the cell. The standard blood test can be very unreliable if any of these conditions are present. And so all these references here are showing that there's reduced thyroid transport in these conditions. So again, the serum levels in TSH often are very misleading. Additionally shown, again, we talked about the different transporters. The transporter for T4 is much more energy dependent than the transporter for T3. So you see all those references there, 5, 40, 41, 49, again available on nahypothyroidism.org. Even slight reduction in cellular energy results in dramatic decline in the uptake of T4. Now, the uptake of T3 is effective, but to much less dramatically. So it will have a slow decline in T3 transport, where T4 is an abrupt, very, very quick decline. Thus, these conditions have a particularly impaired T4 transport and a low cellular hypothyroidism. Again, serum looks fine. That's not what has the effect. It's inside the cell. It's a nuclear receptor. Thus, the cellular hypothyroidism is not detected by serum T4 levels because the less T4 gets in the cell, the higher the serum level. The TSH will also not detect cellular hypothyroidism with these conditions because, again, the transporters for the pituitary are not energy dependent. Well, actually, they can, studies show they have either no effect, energy has no effect, or they might even actually increase their transport. So again, once again, the pituitary is the worst tissue to look at for the rest of the body and to trying to gauge the thyroid effect. So here's a graph on here on the left-hand side, the cellular uptake of thyroid hormone. So 100% at the top, and then then across the bottom here is percent drop in cellular energy, which also goes along with severity of stress, depression, cholesterol levels, insulin resistance, and dieting. So all these things reduce cellular energy. And so you can see with even a very minuscule drop in cellular energy, mitochondrial function, the T4 transporter, which is the green line here, drops dramatically. Okay? So right off the bat, boom, with these conditions, T4 doesn't get into the cell. T3 will drop, but more in just a linear fashion. So you'll get a reduction, but you'll get a reduction in T4 much quicker. Now reverse T3 pretty much parallels the T4. So again, why is that important? Again, because so reverse T3 has a negative effect on thyroid function in that it, as we showed in the last talk, that it blocks thyroid receptors, it reduces T4 to T3 conversion, it lowers metabolism, so it's an anti-thyroid. But it's also a marker for reduced uptake of T4 into the cell because it parallels the pharmacodynamics, pharmacokinetics of the transporter. Maybe the same transporter, they're not sure, but at a minimum it has the same pharmacodynamics. So if you have high reverse T3, it's telling you what? That T4 isn't going to get in the cell, so trying to use T4, you're going to likely be unsuccessful in improving that condition. So here is, again, as you move out with basically, all the TSH and T4 and T3 levels are pretty accurate if the person's totally healthy, not stressed, has no chronic illness, has no insulin resistance, no obesity, hasn't dieted. So in those conditions, yeah, you can use the TSH and free T4, free T3, but with any of these other conditions, the more severe the condition, the less accurate they become. So, and down here you can see the accuracy of TSH drops very quickly. Again, if you're totally healthy with no stress, the TSH will work. But as you get any condition in increasing severity, the accuracy of TSH drops dramatically, as does the T4. The T3 won't drop as dramatically, again, because it's less energy dependent. So you can use a T3 is going to be a better marker. But what's going to be the best marker actually is the free T3 reverse T3 ratio. So as you go down, because you're getting reduced T3, also reduced T4, you can use that ratio, which will be accurate through the basically through the spectrum and lose little accuracy. So you really is the free T3 reverse T ratio is the best current marker for the cellular level of thyroid. So as discussed previously, the pituitary is different than every cell in the body. It has different deiodinases that we talked about. It has high affinity thyroid receptors that aren't blocked by pesticides, plastics, toxins that readily bind to the thyroid receptors in the rest of the body. Also shown to have unique thyroid transporters that, again, totally different than the rest of the body, that aren't energy dependent. You can see the references there. And the references down there showing totally different. This difference was investigated by one study, Germain et al., and you can see in the Journal of Clinical Investigation, study demonstrated that thyroid transport in the pituitary was increased while the rest of the body have decreased transport. Thus, TSH decreased even when serum levels were decreased by 50% due to increased thyroid, pituitary thyroid transport. So we talked about the problem with deiodinases being upregulated in the pituitary with all those chronic conditions, inflammation, stress, diabetes, chronic fatigue syndrome, but also, again, the thyroid transport. So they all go together to basically, now this also, when you have reduced T4, let's say reduced T4, T3 conversion, you'll get basically low T3, high T4, but also again, in the serum, so T4 goes up. So because there's less transport. So again, it's artificially elevating it. So here's just a study here showing different regulation of thyroid hormone transport in liver and pituitary, possible role of the maintenance of low T3 production during non-thyroidal illness and fasting in man. So non-thyroidal illness is basically a poor term they use for basically chronic illness where the pituitary levels, the TSH will drop, T4 T3 conversion will drop, serum T4 and T3 will drop. We posit different regulation of thyroid hormone transport in a relevant tissue, i.e. liver and pituitary, may play a role in the maintenance of low T3 production during non-thyroidal illness and fasting. The data are compatible with the existence of different transport systems for thyroid hormone in the liver and pituitary, which suggests that these different thyroid hormone carriers allow tissue-specific regulation and intracellular availability of T3. And also, it's another reason why you have such a wide variation of symptoms with people who are hypothyroid. It depends on the transporters, depends on deiodinases, which can change with the condition genetically over time. So some people will just get fatigue. Other people will just get hair loss. Other people will gain weight. Other people will get everything. So it is a significant local control of thyroid. So this study here in Journal of Endocrinology and Metabolism, these observations lend further support to the view that thyroid hormone transport in the pituitary is regulated differently than in the liver. And when cultures were incubated with serum from physiologically stressed or dieting individuals, there's shown to be a dramatic reduction in the uptake of T4 by cells that correlates with the degree of stress. So you can basically incubate cells with a stressed person's serum, and they won't uptake thyroid, especially T4. And where a non-stressed person, you're going to get that normal thyroid transport. So very, very telling. Study published in the Journal of Endocrinology and Metabolism found that another study, serum from non-stressed individuals had no effect on T4 uptake, while those with significant stress, there was a 44% reduction in T4 uptake in the cell. So again, what's the standard? You look at the TSH and T4, wow, you're going to get totally inaccurate results if the person is stressed. So shown that the free T3 reverse T ratio was the most accurate marker for reduced cellular uptake of T4. So again, that reverse T3 goes up, showing that there's poor T4 uptake into the cell. T3 goes down. So that's the best marker. In a highly controlled study, Brownell et al. Found that after repeated cycles of dieting, weight loss occurred at half the rate, and weight gain occurred at 3 times the rate compared to controls with the same calorie intake. So, wow, it's like, so when people yo-yo diet, again, they can't lose weight after that, and they immediately gain the weight back very quickly when they go back to normal eating. So chronic, again, this chronic and yo-yo dieting frequently done by a huge percent of the population, shown to be associated with reduced cellular uptake of T4 by 25 to 50%. So, you can basically see all the references there. If we look at the study by Libel, who looked at people, same body fat, same lean muscle, same age, so they should have the same basal metabolic rate, but those who had dieted in the past had a 50% lower metabolism. So, or excuse me, about 40% lower, no, I'm sorry, it was 25% lower metabolism, which is from reduced uptake into the cell and also reduced T4, T3 conversion. So they all go together. So again, now here's, again, we looked at this before. When you look at with chronic stress, chronic inflammation, any chronic illness, this is the serum levels of thyroid hormones. So what you see is basically the T4 levels go up because you have that reduced thyroid transport into the cell. The TSH may go up initially, but as you get sicker, it actually drops. So you're getting a low TSH. The free T3 will drop continuously. So you say, well, what's the best marker? Again, the farther you go out here, the more hypothyroid, the more intracellular hypothyroidism there is. But what is the best marker to determine that? So when you look at, well, T4 isn't very good. It basically goes up. And you say, well, is the person hyperthyroid or low thyroid? TSH isn't very good. It kind of basically doesn't change, that it drops as it gets more hypothyroid. T3 is better, and reversed, when you look at the reverse T3 ratio, is going to be the best. You're going to see the best differentiation of that. So when you divide this by this, you're going to get that best marker for tissue hypothyroidism. So again, the artificial elevation of T3 due to reduced uptake in the cell. So you're getting reduced uptake of T3, but it's dropping because, again, you have the competing effect of poor T4, T3 conversion. So the poor T4, T3 conversions lowering serum levels, but you also have the reduced uptake, so it's not as dramatic, so it kind of stays elevated. So actually, intracellularly, the T3 is actually dropping much quicker, but the serum levels are somewhat counteracted by the poor uptake. But again, the T4 uptake is even more dramatic. So how do you tell if, again, you have reduced thyroid transport? The reverse T3 has, again, same pharmacodynamics, same pharmacokinetics. All the studies there showing that. So again, we talked about the main reason it goes up is reduced transport. So it makes it the most useful indicator of diminished transport of T4 into the cell. Thus, high reverse T3 demonstrates there's either increased T4 to reverse T3 formation or inhibition of reverse T3 into the cell, which is actually, we talked about, as a larger effect. These occur together in a wide range of physiologic conditions, again, making an excellent marker of cellular hypothyroidism not detected by TSH. Also, this T4 is not optimal therapy when you have high reverse T3. Now, people say, well, high reverse T3 can be associated with hyperthyroidism as the body tries to reduce cellular thyroid levels, and it will do that with hyperthyroid patients, Graves patients. They'll have a lot of reverse T3, or if you give a lot of T4, the body will make a lot of reverse T3. And you'll find, too, is hyperthyroid patients actually have much less symptoms for their levels of T3. And nice studies showing that. Why is that? Because they have basically high reverse T3 blocking the thyroid receptors, protecting the body from that high T3. And I think we reviewed some of those studies last time. But so how do you differentiate? Look at the free T3 reverse T3 ratio. And what you have, too, again, we talked about last time, high T3 and high reverse T3, you get oftentimes symptoms of both high and low because it depends on what tissues. So let's talk about a couple of conditions that are basically quintessential examples of this poor transport. So one is depression. Dysfunction with depression and bipolar depression. And again, we talked about downregulation of D1, deiodinase type 1, which is the T4, T3 enzyme that converts T4 to T3 inside the cells of the body, and reduced uptake of T4 into the cell. So it's shown to occur with those, all the references there. Thought to have normal levels of thyroid, usually low normal TSH and high normal T4. So, and so many studies go, oh, they're subclinically hyperthyroid. No, they're hypothyroid. And then they say, oh, they gave T4, didn't work. See, they're not low thyroid. Well, when you give the wrong thing, you basically don't get a response. T3 also stimulates production of serotonin. This study showed depressed patients have reduced T4 transport across the blood-brain barrier due to defective transport protein transthyretin. So basically, genetically, they have a poor transporter to even get it in the brain. So, which is the reason why T4, again, doesn't work for depression, doesn't get into the brain. Have significantly reduced thyroid levels in brains of depressed patients despite normal serum levels and standard thyroid tests, references there, as well as reduced TSH response to TRH. So again, thyroid-releasing hormone, inject that, gold standard, and look at depressed patients, and it shows they're hypothyroid, despite the fact that standard thyroid tests look normal. So it's not surprising that T4 and T4-T3 combinations may have some benefit in depression, but due to suppressed T4-T3 conversion from the suppressed D1, again, type 1 deiodinase in depression, and more importantly, the suppression of T4 into the cells of the brain, and actually even in the blood-brain, across the blood-brain barrier, time-release T3 is significantly more beneficial than T4-T3 combination supplementation. So all the references there. So a couple studies, International Journal of Neuropsychopharmacology, published a double-blind placebo trial of 50 patients with normal thyroid function as defined by the TSH. Patients are randomized to receive 25 micrograms of T3, so low dose, or placebo in addition to their antidepressant therapy. Found almost a twofold increase in response rate with T3 and a 4.5 times greater likelihood of experience a positive response at any point over a 6-week period. Side effects were higher in the placebo group. Okay, on 10, 11 criteria, including significant increase in nervousness with the placebo group. So very, very safe. And it's interesting. You look at the studies on antidepressants. Standard is give SSRIs or dual-acting agents, and what's the likelihood it's going to help that person? Probably 25%. It's close to placebo rate. And you look at meta-analysis shows that for mild depression, that they're not even they're shown not to be any more beneficial than placebo. So adding T3, you're going to dramatically improve that, at least double your effectiveness. Very interesting study here. Investigated the effectiveness of T3 on treatment of bipolar patients who had failed adequately respond to an average of 14 different medications that used to treat their bipolar depression. So they respond to anything. They gave them all T3. The average dose was 90.4 micrograms. It ranged from 13 to 188. The medication was found to be well tolerated. 84% experienced significant improvement, and 33% had a full remission. So these are patients who didn't respond to an average of 14 different medications prior. So one patient who was switched to T4 for cost reasons experienced a return of symptoms which resolved after reintroduction of T3. The authors concluded augmentation with supraphysiologic doses of T3 should be considered in cases of treatment-resistant bipolar depression. Now, when they say supraphysiologic, what does that mean? Well, is it really supraphysiologic? It's suppressing the TSH. It's basically supraphysiologic in the pituitary, but it's not supraphysiologic in the brain. You're just getting those levels back to normal. And the authors would like to thank several doctors, encourage them to go beyond the traditional 50 micrograms of T3 because it has helped so many of their patients. So, and so standard, as you look at, basically the psychiatrists are way ahead of the endocrinologists in giving T3 because they know it works. And it's rare you find an endocrinologist giving, adding T3 or even giving straight T3, especially. Sometimes they'll go, oh, they're crazy outside the box, and they'll give 5 micrograms of cytomel or something. STAR report, largest study ever done on antidepressants. They found that for over 4,000 patients, found that 66% of patients failed to respond to antidepressants or have side effects severe enough to discontinue use. Of those who do respond, over half will relapse within a year. So even based on this, you're looking at basically a 15% long-term response rate. But the trial found that T3 was more effective even when other medications such as Celexa, Wellbutrin, Zoloft, Effexor, or cognitive behavioral therapy were not. It was shown to be 50% more effective even with less than optimal dose of 50 micrograms under direct comparison with significantly less side effects than the commonly used therapeutic approach with standard antidepressants. So it was a step care where they had people that they didn't respond to this, they got this. And it's interesting, you look at the data's right there, but they don't even mention it in the abstract. So it's like, hello, you got a treatment that has less side effects, was more effective, and for a political reason they didn't mention in the abstract. So, this is typical, oh, it just sounds like you're a little depressed, missing the obvious low thyroid, because all the patients have low thyroid. So let's move on to thyroid resistance. General term, where thyroid just has less of an effect, so it could be for a number of different reasons. You'll hear thyroid resistance, and if you tell an endocrinologist thyroid resistance, he thinks the rare genetic defect of, basically receptor is abnormal. So, which is rare, but thyroid resistance is very common, but it can be from a number of different things. It could be reduced T4, T3 conversion, reduced transport, receptor blockage, where we talked about toxins, genetics, or infection, reduced translation, so post-translational, so the thyroid gets into the cell, it binds to the receptor, but then it has to be activated downstream. You have to basically stimulate proteins that then basically have an effect. So a lot of things will block that post-receptor translation, including toxins, infections, all those things. So how do you diagnose it? Well, generally it's a clinical diagnosis. There's no blood test will detect resistance, but again, if it's due to poor T4, T3 conversion, poor transport, you can have a clue to that by looking at those serum levels, also looking at sexual reminding globulin, and some other things that we'll talk about. You can remove the resistance by removing causative agent, or overcome the resistance by increasing levels of T3. So this is metabolic base of fibromyalgia-related disorders, the possible role of resistance to thyroid hormone. So just the yellow there, overlapping symptom complex suggests that chronic fatigue syndrome, Gulf War syndrome, premenstrual syndrome, post-traumatic stress, breast implant silicone sensitivity syndrome, bipolar affective disorder, systemic candidiasis, myofascial pain disorder, and idiopathic environmental intolerance are similar enough to fibromyalgia to merit investigation for possible thyroid resistance. Acquired resistance may be due often to recently recognized chronic consumptive coagulopathy, so which is where fibrin basically reduces that transport into the cell, which is why heparin is a great treatment for fibromyalgia and chronic fatigue syndrome, which may itself be associated with chronic infections and with mycoplasma-related microbes and parasites. So it goes along, you can read the rest there. This is showing that basically immune activation chronic fatigue syndrome suppresses activation of that thyroid receptor. So yeah, you may get thyroid binding to the receptor, but it doesn't do anything. Here's mutations underlying euthyroid fibromyalgia, basically abnormal SNPs. Fasting decreases T3 receptor capacity. Okay, so it again doesn't, you get less T3 receptors and doesn't bind. So starvation-induced decreased sensitivity of resting metabolic rate to T3. So with fasting, you basically give the same amount of T3. It has much less of an effect. So the activity of many hormones is not only dependent on the availability of the hormones, but can also be influenced by the sensitivity of target tissues. We conclude from these experiments that starvation altered thyroid hormone activity at least two ways. Clearly, effective serum concentrations of T3 and T4 were decreased by starvation. Again, you get that poor T4, T3 conversion. In addition, starvation decreased the response to a given dose of T3, so it can have reduced transport as well. It seemed to be primarily related to decreased sensitivity to T3, particularly with replacement doses. So it stopped working. Iron deficiency basically will cause a thyroid resistance and also reduces T4, T3 conversion, but also causes a general thyroid resistance and will lower metabolism. People think, well, they're tired because they have low iron, less oxygen transport, but they're not anemic. It's mostly due, or a large part is due to the reduced thyroid activity. We talked about toxins. The study here, flame retardants accumulating in people's bodies are blocking thyroid effect. Organic chlorine compounds, PCBs, synthetic chemicals, pesticides, plastics. Well, one thing they said, alligators in 3 lakes. One lake was very polluted, one was medium, one was pretty pristine. TSH levels all the same, but they found reduced thyroid activity in the dirtiest lake. Bisphenol A. So bisphenol A will block the thyroid receptor, but not in the pituitary. So people drink all these plastic water bottles. I laugh. They're on their treadmill going, oh, I'm so healthy, and raising their metabolism, and they're blocking it by drinking all these water out of these plastic water bottles. Again, the standard thyroid test looks normal because it's blocking at the cellular level, but not at the pituitary, because the pituitary has basically the resistance to blockage, their high affinity for the thyroid hormone. Again, here's showing that bisphenol A blocks the thyroid receptors, but no change in TSH because, again, it doesn't block at the pituitary level. This is the first report that BPA can antagonize T3 reaction at the transcriptional level. So again, the thyroid just doesn't do anything. It may disrupt the function of various types of nuclear hormone receptors at their cofactors to disturb our internal hormonal environment. Journal of Clinical Endocrine Metabolism. Chronic fatigue syndrome. Almost all chronic fatigue syndrome fibromyalgia patients are low thyroid. It's a combination of secondary, tertiary, reduced T4, T3 conversion, increased reverse T3, reduced thyroid transport, and thyroid hormone resistance. They have all of those things. Here's a 10-year study, 92 patients, 10% had primary hypothyroidism, 45% had central, 34% had thyroid hormone resistance, and so 89% had hypothyroidism, but only 10% would have been detected by standard blood tests. So the incidence of primary hypothyroidism was 2 to 10 times higher than the general population. Central was 250,000 times, and thyroid is 100 times greater than the general population. So, basically, all those patients low thyroid. 30% reduction in resting metabolic rate in fibro patients. Now, looking at treatment, here's a study of medical hypotheses, so that basically patients only recover if you give them T3. And that it possibly due to some sort of mutant thyroid receptor or thyroid resistance. Again, physiologic doses were safe and significantly effective in the treatment of euthyroid fibromyalgia. Though the thyroid function test looked like patients were hyper, they had no clinically adverse effects. Different study. Basically, at 4 months, none of the patients that entered the study had fibromyalgia after they met the criteria after they're treated with T3. Another study there, powerful effective T3. Let's talk about diagnosis. So the standard way to diagnose, again, is based on that elevation of TSH. So we're taught thyroid levels drop, TSH increases, just look at the TSH. Patient come in, numerous complaints, but majority of doctors will not treat because they have a normal TSH. So this is a review of its symptoms. Really look at, clinically, what's we'll look at, serum levels, what you use to diagnose, but really it's a clinical diagnosis because of all you don't have perfect markers for what's going on in the tissues. So you can have, anxiety with low thyroid, also with high as well, lack of sweating, weakness, pale skin. Thyroid dilates the vessel. So you basically with low thyroid, you'll get patients with pale. You also find that with men who, especially like diabetics, have low testosterone. They look pale. There's a lot of guys low testosterone, low thyroid, which they are. Again, we talked about last time. Diabetics have 40 to 50% reduction T4 T3 conversion inside the cell. Also reduced thyroid transport. PMS. Looked at studies last time. Majority of patients with PMS have low thyroid, and giving thyroid will significantly improve PMS. Heavy menstrual flow, muscle and joint pain, poor motivation, water retention, migraines, fatigue, depression, weight gain, difficulty losing weight, cold extremities, dry or coarse skin, constipation, cold intolerance, hair loss or dry hair, poor memory, poor concentration, fibromyalgia, depression, diabetes, aging, inflammation, PMS, neurodegenerative diseases, dieting, chronic infections, leptin resistance. And we talked about leptin last time. With high leptin, TSH is unreliable. So we reviewed this. Basically, you have to look at the whole picture. So on physical exam, what do you see with low thyroid? So usually overweight, but you can also be underweight, which we'll see with, especially with some of the chronic fatigue syndromes, patients who have low adrenals, who are really chronically sick and are more of the immune activation type. They just look very sickly, but the majority of people will gain weight. Hair loss. Typically hair loss all over, dry, brittle. If it's hair loss just on top, think low estrogen. And then if it's more male pattern, think high DHT. Periorbital puffiness, large tongue. It's pretty rare to see that, but some people go, oh my God, it feels like I've got marbles in my mouth. Swollen thyroid. We talked about, even with just people with fatigue, they gave them all thyroid regardless of levels, that they basically, they all improved, and the majority had inflammation of the thyroid, even if they were negative for the TPO and antithyroid globulin antibodies. Because all we do is check 2 antibodies, but there could be hundreds. And actually, so a lot of those patients will have inflammation of the thyroid, but again, they're not picked up by standard blood tests. Brittle, slow-growing nails, dry skin, cold extremities, dry heel. Cold extremities, if someone says they wear socks to bed, positive sock sign. I've never seen a person with normal thyroid who wears socks to bed. So relaxation phase of the ankle reflex, and you can use a thyroflex for that, measure that objectively. Studies show that that's a better marker correlates with symptoms better than blood tests. Low basal metabolic rate and low body temperature. Although be careful by going just by body temperature, because any chronic illness will lower mitochondrial function, so you get basically the mitochondria make the energy for the body and generate heat. So if those are dysfunctional, yeah, you'll be low thyroid because of the poor transport into the cell. But if you keep giving thyroid based on that, that may never go up, because they have, if you don't get rid of the infection or whatever the underlying condition is, and you may end up overdosing those patients. So what do you check for? We found that TSH is unreliable, T4 is unreliable, free T3 is not perfect. Well, what do you basically check? So TSH, free T4, free T3, reverse T3. You can do thyroid receptor. I wouldn't. It's pretty rare to have that come up. TPO, antithyroid antibody. You can also do anti-T3, anti-T4, but again, those are pretty rare. It depends on the laboratory. And we'll talk about some other tests as well. Sex hormone binding globulin. I'll talk about this now, but we'll address it later. Sex hormone binding globulin. So what does that measure? SHBG goes up in response to 2 things: the amount of estrogen in the liver and the amount of thyroid in the liver. So if someone has low SHBG, if their level is below, let's say, 70 for a woman and about 30 for a man, then they either have low estrogen or low thyroid. So determine if one or both they have if they have low SHBG. Also, if you give thyroid, we're going to talk more about this in part 3, I believe, that in their SHBG doesn't go up, then you know they have thyroid resistance. Now, if they're taking oral thyroid, the oral thyroid will go through the liver first, so they'll have a much higher level of T3 in the liver. So if they don't have a high or high normal SHBG, it's a marker you're not giving a thyroid. So it's another piece of information of cellular levels of thyroid. And again, we always, 95% of people are normal, and I think most of you, know about this, where, the highest and lowest 2.5% are considered abnormal. So normal is, it's just basically showing that, hey, you're, only 2.5% are lower than you. If you're lowest 3%, you're considered normal, which is crazy. So think more optimal rather than normal. So typically good news, your test indicates that you're in the normal range. This is a Today Show. I'll skip this because of time, but on the Today Show, it was a nurse practitioner that came in, basically, who was told she had normal thyroid, was treated dramatically better. Of course, they interview the endocrinologist, says, oh, there's no science behind that. He's just putting on hands, But I'll skip that due to time. You can see it on the website. So best method diagnosis, look at the T3 or the free T3 to reverse T3 ratio should be greater than 2. Free T3 should be above 3.5. Reverse T3 should be less than 150. Look at the studies where a healthy person, reverse T3 is going to be less than 150. TSH greater than 2 is significant. So again, the pituitary always sees the most thyroid. So if the TSH is high, the pituitary is not getting enough thyroid, you know the rest of the body is not getting enough. So that is significant. So TSH is specific, but not sensitive. So if it is above 2, you know they're low. If it's not, you don't know. So usually you'll find a low normal T3, free T3, and above normal reverse T3, which is really why that ratio is the best. Look at signs and symptoms. So studies here showing that the T3 reverse T ratio is the best marker for tissue thyroid activity. I'll see what slide are we on. I just got a couple more, and this will take some questions. So this is 4 to 3 men investigate association between TSH, T4, free T4, T3, thyroid binding globulin, and reverse T3, and correlated with tissue levels of thyroid effect. They demonstrated that TSH and T4 levels, as we would expect, were poor indicators of tissue thyroid levels, and that couldn't be used to determine if a person was euthyroid or not. In fact, the T4 had a negative correlation, which we talked about. So high T4, low thyroid effect. Demonstrated reverse T3 was the best indicator of tissue levels of thyroid, and also that the T3 reverse T ratio was currently the best indicator of thyroid effect, and poor sensitivity of TSH and T4. And Journal of Endocrinology Metabolism, this is their journal. So these high reverse T levels were accompanied by high T4 levels. Again, this is what we would expect, and explained by decreased peripheral conversion of thyroid hormone metabolism, increasing, but they didn't even understand about transport. Really, that's what it's more from. So other studies, misleadingly low free thyroxine index, usefulness of reverse T3. And again, remember these we went through. They're showing the thyroflex. Look at the relaxation phase of the ankle reflex correlates with tissue level of thyroid. Better test than standard blood tests. 99% specificity, 90+% specificity and sensitivity. Patients love that test. Basal metabolic rate, great test. Look at the, what's their metabolism. People come in and go, God, I wrecked my metabolism. And their husband, oh, sure, you must be eating ding-dongs when I'm sleeping. We find if they truly have, and you look at those patients have very high reverse T3. Age modulates effect of thyroid dysfunction on sex hormone binding globulin. And so this is a measure that you can use a measure of thyroid level. So in young women, average sex hormone binding globulin was 24 in hypo, 43 in euthyroid, and 153 in hyperthyroid patients. Older women, it averaged 37 in hypo, 69 in euthyroid, 115 in hyper. Younger men, it doesn't differentiate as well. 15 in hypo, 27 in euthyroid, and 107 in hyper. Older men, again, 42, 54, and 83. So it's especially useful for women. This is basically a study here again showing that sexual binding globulin is a good marker for diagnosis of low thyroid. Another one here. It should increase with administration of thyroid. If not, you know you have thyroid resistance. And leptin, let's see, should I stop here so I can take some questions? So we'll stop. We were a little farther, but I'll leave lesson for next time. And which I thought we already talked about it a little bit, but we'll go into that. Let's see if we'll start taking questions now so we can get through some of those. Now what? Okay, so the question here is, let's see. In the last talk, you stated that T3 reverse T ratio should be above 2. Is it T3 over reverse T3? Yeah. So it's really, the best marker is free T3, reverse T3. Again, the unit we talked about last time, units don't work out when you do that. So people say you need to use T3. Well, I don't care so much about the units. I care about what's basically going on, how good of an indicator it is. So yeah, it's the free T3 to reverse T3 ratio above 2. Can you put the diagnosis slide up again? Oh, are references listed on your website? Yeah, they're listed on the National Academy of Hypothyroidism. It's our nonprofit site, nahypothyroidism.org. And let's see. Can you put the, sorry, do you have nursing CEUs? I'm not sure. How do you test and treat a 14-year-old with possible hypothyroidism? Same way. And with kids, I would generally not suppress the TSH if you don't have to, just because with kids you always be a little more careful. Just as anyone over 65, we would be careful of suppressing TSH, just because you'll freak out parents, you'll freak out the pediatricians, and with the AFib, we'll talk about AFib and osteoporosis. That actually giving T3 reduces the risk of AFib in a lot of studies. Too much, it will increase your risk, but also too little increase your risk of AFib. So kids the same, and you'll find the kids dramatically improve. ADD, you get the kids are sluggish, they're not doing well in school, they're overweight, and you find that they have basically high reverse T3, low free T3. Now, the problem is in the kids, they go to the pediatrician, and they'll think that a TSH of 9 is normal. And so, a lot of times you just bring those kids down and just give them a little bit of T3, and they just do dramatically well. Let's see. If patients on Synthroid, how is this affected in thyroid hormone transport? So with T4, again, the problem with giving T4 is that it doesn't get into the cell. So you'll get actually a upregulation of the type 2 diet, so it'll convert more to reverse T3. And basically giving the T4 just doesn't do anything. It just doesn't convert. It doesn't get into the cell. Especially if they're totally normal and healthy and have no stress or inflammation, T4 are probably fine. But the sicker they are, the more T3 you need. Now, occasionally, people will say, they'll check the T4, oh my gosh, the T4 is low. If you give T3, T4 drops. That's what it should do. Oh my God, their T4 is low. Well, who cares? The only reason you have T4 is so it converts to T3. Now, occasionally, some people will feel better with some T4. But we find that probably 70% of people feel better with straight T3, and about 10% need a little T4. And it doesn't matter, you can use either. And occasionally, some people can't tolerate T3 at all. But that's a very rare case, but majority of people feel better with straight T3, or if they're not so bad, a T4, T3 combination. What's the opinion of urine iodine testing? And that's actually what we use. There's all different ways to do things, and remember, tests are a piece of information. There's no perfect test. All tests have their limitations, and so you need to use them as a piece of information and not just rely everything on a test. So we use urine iodine tests. We basically run on every single person that comes in, and you'll find again iodine. We think of, well, it's needed for the thyroid to work, but it also with low iodine will cause thyroid resistance. So with low iodine, it just doesn't work very well, and you'll find a number of people with low iodine, which is very common. All of a sudden you give them iodine, the thyroid starts working. Same thing with iron. So you want to be sure your patients have good iron. Is there any more questions? Let's see. 12-year-old male with Hashimoto's. With Hashimoto's, how do you treat that? With Hashimoto's, they're low, and a lot of people say, oh, it's basically their thyroid levels are fine, You don't need to treat them, but if you treat them, they'll feel much better. With the Hashimoto's, you're destroying part of the thyroid, so your thyroid levels are dropping. But also the problem is as the antibodies are destroying the thyroid, it's dumping thyroid in the tissue, in the serum. So you get high and low. So people kind of go up and down. And also that inflammation will, again, reduce thyroid transport, reduce T4-T3 conversion. So what do you do with those patients? Well, one study showed just giving selenium can reduce thyroid antibodies by about 40%. That was in Journal of Rheumatology. Low-dose naltrexone, great treatment for reducing autoantibodies. Giving testosterone, men don't get Hashimoto's that often because the testosterone protects them. So you want to optimize all those things, and you can get improvement in the reduction of the antibodies, which is key to optimally treat that patient. And let's see, references, we saw that. Can you give a child iodine? You know, with kids, just to be a little more careful, but you can certainly, if they're low, give children iodine as well. If you put the diagnosis slide up again, I think I can go back here. Nursing cells, 214. I think that's, yeah, I think that's all the, 21. What is the best dose? Okay, when starting T3, is it best to start at 25 micrograms? I'd say no. Most people would tolerate that, but you got to be careful. You're going to have a few patients that are very sensitive. You want to start low. You can ramp up rather quickly, but you want to be careful. So most patients will tolerate very well, but we usually start 10 micrograms and ramp up from there. So and we'll talk more about that in the treatment part 3.
Okay. Well, Ken, I think we're running out of time.
Great. Yeah, I think we're at a good place to stop, and I thank everyone, and we'll hopefully see you guys for part 3.
Thank you very much, Dr. Holtorf, for taking the time to be with us today. I want to remind everybody that there will be a part 3 of the presentation. We'll be scheduling it in about 2 weeks' time. As soon as we have a date and a time confirmed, we'll send out a notification to everybody that participated in today's event and anybody that has already registered for membership in BHI. Membership at BHI is free, so if you're interested, we really welcome you to go to the website, www.bioidenticalhormoneinitiative.com. Once you've registered, you'll receive notifications from time to time when we have these events. I'd also like to remind everybody that the references that Dr. Holtorf referred to today in the presentation can be found on his website, www.nahyperthyroidism.org. Also, on the BHI website, we have discussion forums, including a category for discussion about hyperthyroidism. I would encourage you to go there, check it out, ask your questions, and we'll get back to you and hopefully engender some interesting discussions about the topic. So make sure you return for the final installment. The date will be announced. You can find information on the website, bioidenticalhormoneinitiative.org. Thank you very much for joining us today.
Thank you so much.